And just in general, as I mentioned in the post-COVID era, a lot of the vascular inflammation, I mean, I'm really thinking about it more in terms of the blood thickening effect, the fibrin effect, and everything at a core level, that I'm doing full coagulation profiles on people, whereas before I might not have done that with like every single person. But now, I mean, I've even seen that they've changed the reference range of fibrinogen and they've put it at a higher number in LabCorp, for example. So it's kind of like the average population is really just more coagulable than they've ever been before. And there's some evidence that some of these Babesias or even possibly Bartonellas can sort of hide in these fibrin, arrangements. So we kind of have more fibrin, and then we have more of that maybe enveloping these areas too. So it's incredibly integral to do the evaluation and the work with the coagulation and the blood thickening process and whatever that looks like. And there's a lot of ways to do it, of course, between your enzymes, and if you have to use heparin or other blood thinning tools, you certainly can. That's why it's important to get an individual profile and individual perspective. And
good morning. Really, it's a pleasure to sort of talk today with Dr. Jamie Kunkle. Dr. Kunkle is an amazing physician who has been working with us for the last 2 years now. And he came fully formed, I would say, because we have been treating chronic tick-borne diseases and chronic complex illness for the last 20, 30 years. And over the years, we've had many physicians come join us. And it's often been a very long learning curve. And the pleasure of having Dr. Kunkle is that he joined us and he had already been on this journey. And so today we're going to talk about his experience and some of the questions that come up when people have been dealing with chronic complex illness, especially those that are related to tick-borne disease. So good morning, Jamie.
Good morning.
And so I think really what people don't understand is often that, there's a journey to get people who are interested in this field and get people to really become proficient in the field of chronic complex illness, because it's not something that we're taught. So how did you get here? What was your origin story?
Yeah, no, this is a really good question, and it probably goes a little further back, but I won't spend too much time on the early details. But I started off wanting to learn about neuroscience, or the brain, and I think that was really important to me because it was something that was so unknown, and we still don't know, too much about. And that was kind of just really interesting to me to kind of dive straight into something that was an emerging field, an uncertainty or a mystery, so to speak, and understanding even how my own brain works. So, so I started kind of there, and then I was pre-med and I kind of started looking into conventional medicine, and I wasn't really entirely liking sort of the idea of having an open mind and being progressive and all this kind of thing, and also not really using natural medicine and kind of more nature-based practices. And so I kind of found naturopathic medicine at the last minute and went and did that. And then it was a great journey there. And then I also started learning traditional Chinese medicine systems, which I think has really enhanced my just foundation of understanding complex cases, because there's a lot of, I guess it's a general concept of what they call pattern differentiation. It's just differentiating a lot of really complex patterns and trying to distill them into something that is important, actionable. I'm just getting the diagnosis correct, but understanding all the external influences that may be affecting that individual at the same time. A multi-systemic approach, which was also, part of the naturopathic philosophy, but just understanding the interconnectedness between all the different body systems. And even though the Chinese system had a different language, it was all still patterns of human disease and human illness on the mental, emotional level, on the physical level, on the spiritual level, just so many different things. And so having that foundation to begin with was really important. And I kind of fell into a complex chronic practice in about 2015 or so. And prior to that, I was doing a lot of primary care, I was doing a lot of physical medicine, I was doing a lot of acupuncture, body work, and different things. And I started already seeing these patients then, and they already kind of started noticing me. They always say that, people who are appropriate for you in this world are maybe drawn to you, and that's not much different in medicine, I think. So I already started seeing them, and then I kind of just dove head first into a clinic that was a lot of that, whole families that were in that world, probably genetics, genomics, and different things, and really started seeing it a little more on a regular basis, on a daily basis. And I was also fortunately with a mentor that was, versed in this as well. So with that together, it really just sort of pushed me into it. And I think if you're good at this work, you stay in it. If you enjoy it or it does something for you, you're going to stay in it too. You don't just do it just because, or for whatever other gains that you may have in this world. And on a personal level, I come from Pennsylvania. I come from the East Coast, like a lot of us in this game. A lot of Lyme there. It's affected my family. It's affected my immediate family. In some ways, it affected them. Some of them later, after I started this journey, which was really strange. And maybe it's just something I noticed more. I was more recognizing, but it kind of didn't start out personal, but then it like really became personal at the same time. But it's not entirely personal at the same time. But it still was a motivational force nonetheless to understand it better, because it's something that affects my immediate environment too. And I lived in Vermont for a while. I get to see the lovely endemic, very deeply endemic areas of complex acute Lyme, emergent, urgent issues that are associated with Lyme too. So kind of dealt with the whole spectrum here. But yeah, it's so then I've just kind of continued to evolve that practice, and you really have to have a drive to learn with this. I never feel too comfortable or confident, and I appropriately confident, I guess I should say, but just sort of also appropriately critical at the same time. And that takes a certain kind of mind too, I'd have to say. You can't be too ego, too too overly sure of anything at any given time. You have to evolve your thinking. You have to evolve the models, the paradigms that you operate off of. And so, yeah. So
I just want to emphasize what you, I mean, that's probably is such an important thing for people to understand who have this illness, is that I hate to say we don't know what we're doing, but there's a part of medicine, what we would talk about, the acute care models, where there's lots of rules, because there is a pretty good sense of like what works and what doesn't work. But once we get into chronic illness, as I say, it's about your body, the person who has the bug or had the bugs, and how their body is reacting on a chronic compensatory model. And that's where the exploration goes on forever, because people are different. And so even though the trigger might be the same, the end result is different. And that's where as you said, the pattern differentiation, recognizing patterns, but be able to like differentiate between them, because the testing is evolving, thank God, but it's not great. And that's where that inquiring mind and always looking is important, because we are always learning with our patients. And so when it comes to the tick-borne diseases, the pattern recognition is so important. And so are there new patterns that you're seeing, new bugs that are or that you're beginning to play with and notice are bigger players than we thought?
Yeah, I think that pattern's always changing for a lot of reasons too. I mean, it's not just me, maybe learning or recognizing it more, but it's how the world's been changing too. I think that the obvious one, the elephant in the room, is always how COVID has affected our immune systems and affected the terrain and affected the environment and affected our relationship with infections in general. So I think since then I've been seeing different patterns. And so, for example, Babesia, for whatever reason, in the last 2-3 years, it's a parasite that's associated with tick-borne illnesses, and many of you probably know that. And I've been seeing that a lot more for whatever reason since COVID, and maybe I've just been hyper focusing on blood inflammation or blood infections in general, because that's what COVID sort of is doing too, active in the blood. I don't know what it was, but that was just an example of something I've been noticing more. And now we're seeing more. There's a potential new species out there, Babesia coli, that we've been hearing about a lot, and it's not easy to test for. And that and Bartonella together, both being blood infections in the post-COVID realm, have been a big deal. And there's so much more than what we thought was there. So if you don't see a positive on the usual dudes, there might be several others, and those might be significant, and so I've had to kind of adapt in that way. It's interesting, maybe just for the times, once again, there's increasing toxicity in our environment, and then there's infectious disease that just hit all of us in some way or another, and some of the associated toxins with that too, and even emotional and traumatic and otherwise. And so I just see maybe it's the susceptibilities to certain bugs possibly as well, or maybe climate change is playing a role, who knows. But every year, every couple of years, it seems like the emphasis can shift and change here, and that's why you have to keep an open mind, and you have to look for it. You don't want to make assumptions either, just based on patterns of presentation, because the symptoms are the response or lack of response. There may not be symptoms to these things, but when you have more than one of them, 5 of them, 6 of them, all bets are off. So yeah.
I think you said a bunch of important things there. The COVID piece is just so important. I mean, that's something that I have to kind of like remind myself every day. Is that things between the illness and the vaccine, that immune systems have changed, and that's been mind-boggling. I think is that sort of like it's like there's a little bit like a story of like you don't notice the air because it's all around you, and the same thing with COVID. It's like it's slowly, and then suddenly we're noticing that all of our patients, when they're presenting, there's a little different flavor sometimes, and you're right, a lot more affecting the vascular systems, and the Babesia popping up. I've been surprised at that as well, because I used to think Babesia had a when people were like had that what I call that really soul-stealing depressions, like the suicidal depressions. I mean, and air hunger and things of that sort, they were the big, but I'm seeing a lot of Babesia in people now who don't have those things, and and I think it's because, again, our tests are improving now with the immunoblots and the cultures. We're finding, because in the past we were stuck with the only thing we could really see was Babesia duncani and Babesia microti. And there's obviously, I forget what the number is, was it 20 or 30 different known Babesias out there, and so with these non-specific tests, we're seeing more showing up. And how is that been pushing your therapies in a particular different direction? Have you what have you found with like you said, the Otacali? Dr. Lindner has kind of brought this to our attention, and now the testing is, at least we're seeing something that's not microti and not duncani.
Yeah, totally. And props to Dr. Lindner for sort of bringing this to our attention, for sure. I mean, it's been amazing, the work he's been doing to progress this. And I would say that, yes, and just in general, as I mentioned, in the post-COVID era, a lot of the vascular inflammation, I mean, I'm really thinking about it more in terms of the blood thickening effect, the fibrin effect, and everything at a core level, that I'm doing full coagulation profiles on people, whereas before I might not have done that with like every single person. But now, I mean, I've even seen that they've changed the reference range of fibrinogen, and they've put it at a higher number in LabCorp, for example. So it's kind of like the average population is really just more coagulable than they've ever been before. And there's some evidence that some of these Babesias, or even possibly Bartonellas, can sort of hide in these fibrin arrangements. So we kind of have more fibrin, and then we have more of that maybe enveloping these areas too. So it's incredibly integral to do the evaluation and the work with the coagulation and the blood thickening process, and whatever that looks like. And there's a lot of ways to do it, of course, between your enzymes, and if you have to use heparin or other blood thinning tools, you certainly can. That's why it's important to get an individual profile and individual perspective. And as far as Ota coli goes, yeah, it's been challenging. I think that, and right now there's like a shortage of the one drug that they were using, hopefully successfully, which is tafenoquine or crintafil. And that's a once a week, pretty aggressive treatment for Babesia, but seems to be working on Ota coli. And I've still defaulted to trying to use ozone with heparin if I can get IVs in there. I still think that's been working quite well in some cases, but it's because it kind of does two of those things at the same time. There's a lot of immune modulation that goes around that, of course, as well. And I have been still seeing success with just progressive treatments between herbs and the starting antibiotic combinations, even azithro and mepron, although there is some evidence there could be some resistances out there to mepron or tovaclone. But I use a lot of artemisinin too. So in methylene blue, there's been some fun stuff there. So I've been kind of following through with the progressions, but I think it's been going okay, but there's still some mysteries there because obviously not everybody just magically gets better with those really baseline treatments. So there's probably a lot of other individual factors at play. And with the COVID thing, I mean, there's no way for us to really know if there's like a persistence of spike protein in the blood or if there's a continued activation that's happening on another level, I think, that is either dysregulating the immune system, making them more coagulable, or causing any other number of dysregulation effects. So it's a challenging time for sure. You really have to take it on a case-to-case basis and kind of unravel it like we normally do.
Yeah, because the inflammation that's in the population has gone up with COVID. I mean, that is for sure. I was just speaking to a friend of mine who's a dentist, and there's a very, what in the past was a very rare condition where the little bit of tissue that kind of holds your teeth tight in place can get inflamed and give you loose teeth. And, she said in a young person, she'd see this maybe once a year, once every 2 years. And in the first 6 months of the year, she's had like 4 young people with this in rather advanced states. And and so it's got to have something to do, I mean, probably with COVID. And, but with the issue we have in the complex chronic illness, again, is that it's not rare, but it's not common in the sense that, like most people are still doing just fine, for day-to-day life. It's just that we have more people who because of either infection or environmental toxicity or their genetics are having more problems. And so it doesn't get to that population level where the medical system notices. I mean, the only reason long COVID has been accepted is because it got so many people at the same time. They've ignored chronic fatigue for 50 years just because it would be, so few people got it at the same time. And so it wasn't obvious. So the medical community sent people just to the, psychiatrists. And now long COVID is at least getting some more traction. But
I think Lyme is too, to a degree. It's more so than it has in the past. And I think that maybe because the numbers are going up there too, or there's at least some recognition, and we could get into descriptions and nomenclature, but what they call post-treatment Lyme disease syndrome, there's a recognition that there is a chronic form of Lyme now, or that there could be, whether they were treated or not. In the mainstream, I'm talking, not in our world, but that's at least creating more recognition in that world too. I mean, I'm seeing it more on the mainstream media than ever before. I think whether they're describing it accurately or not, it's still a conversation that's starting. And I think COVID sort of really set off the need to do that, the impetus to even be attentive to it and fund research or whatever it's going to take for us to all come together as in the broader medical community.
Yeah, I think that's so important because the post-treatment Lyme, I said not our favorite term, but to be fair, there are probably a fair number of people with chronic Lyme, who the Lyme has been controlled, and it is the immune system that's just dysregulated, or the autonomics that have been hurt. And that's real, and what I always like to remind people that when they go to their doctors and their doctor or especially when they go to a specialist, because it's often more the specialist who feel that, like, they read the Infectious Disease Society of America, statement on Lyme disease, and therefore there is no such thing as chronic Lyme, and people need 3 weeks of antibiotics, and if you're not better, it's not Lyme. And those are what I call the political wars, because to be fair, I think the Infectious Disease Society came up with that attitude because they were concerned about those of us who sometimes treat people for a very long time. And what they have to understand is that sometimes, the difficulty is some people do take a long time to respond with antibiotics, and other people, the antibiotics aren't helping them. And it's and this is the art, and something I know that you pay a lot of attention to, and we as a clinic, making sure that we're not continuing to treat when the Lyme is gone. And so how do you, which I said, this is a big problem for those people who are ill to understand, is that the symptoms don't always go away. So how do you parse that? How do you look at those people?
Yeah, absolutely. And I try to tell them too. There is probably such an entity as post-treatment Lyme disease. We can't always assume that it's just, the bugs are still there all the time, especially if they've been through, nuke the earth kind of treatments out there, which some patients do come in that have like 4, 5, 6, 7, 8 antibiotics or more. And you have to wonder if it's surviving through that. So new testing, I think, is going to help guide this process. I also have to parcel out the symptoms too, because a lot of times there is an immense amount of lingering autonomic dysregulation. Like I was just talking to Eric about my uncle who had, hospitalized with Lyme 3 years ago, and he still has dysautonomic issues of elevated heart rate, and then goes low heart rate, up, down, and all around and everything. And so theoretically, they gave him enough IV antibiotics that he didn't have anything left there anymore. But the new testing in question that we use, the one I'm very excited about, is brand new pretty much, and that's the culture, the amplified culture through IGeneX, where they take a blood sample, they put it in a proprietary medium that mimics human whatever bioactivity or whatever, and then they do a PCR or DNA arrangement on it. And so they're finding things as a direct test to try to reevaluate the presence of these things. So if there's really not a lot of DNA, we really can't always assume that we can sterilize a system 100% in a chronic infection. However, we can certainly marginalize the heck out of it into a place where it's really not doing too much. So you would hope that the PCR testing shouldn't really pick it up to a large degree, because there's not going to be a lot in the blood anyway with some of the creatures like Lyme, Borrelia burgdorferi and friends, because they don't live there all the time. But if you killed a whole bunch of it and you've given it time to try to recover, and then you've drawn the blood and then amplified the sample and it's not there, hopefully that means that it's not there. That's one thing. The other thing is that if you're looking at the immune system, I personally feel, and a lot of people agree with me, I think that the serology or the antibody testing isn't always the best way to really see if somebody still has an illness or not, especially because some people don't have a proper antibody response. And that's part of how Lyme, Borrelia burgdorferi, and friends, other Borrelia species especially, trick the immune system. So sometimes they hide, or they reduce or suppress the ability to have those responses effectively. And you even see in really chronic people that sometimes their immunoglobulins or their antibodies will even go down. They'll go like more immune deficient even. So we turn to some of the T cell testing or the lymphocyte response testing too. The caveat to that is that sometimes that system isn't working very well either. But if you've established that in the beginning, that it is sort of working on some level, that you can see where the immune system is putting its attention to, you can use it after treatment, post-treatment, and see if they're still having a response or not. And the hope is that if they're not having a response, that they're clearing. So I think where I'm going personally, is a direct and indirect test to monitor, and probably using some combination of that culture and that T cell testing, probably literally doing both in my opinion, as an objective tool, and then really being clear on the patterns of their current presentation in a post-treatment world. And if they look more like dysautonomia, there could still be possible mast cell or other things too, or maybe there are connective tissue or structural issues within their system, to really try to differentiate that if possible. And maybe there's still some cleanup I need too. Maybe I need to treat EBV or something, who knows? Maybe there's a post-COVID layer. Maybe there's mitochondrial disorders. We'll talk about testing for that possibly too. So if I can really do that objectively and then retake their case, like reevaluate them entirely, including physical examination, ideally, I can get a much better idea if we're past the bugs or not.
Yeah. Well, so just to you said a lot there.
Yeah.
So just so people just to reiterate again is that so what we've always used is these antibody tests, and antibody tests mean that the bug has to create the signal, the antigen, and then your body has to make the antibody, and then we measure whether you're making a lot of antibodies to that bug. And so that's a complicated system that usually works pretty well. But in some people with Lyme, especially, the bug can kind of modulate that a little bit, or sometimes just really hide itself. And so you're not seeing, it's not making many antigens. So those antibody tests don't always work. And that's where we got the T cell tests, which is a different part of the immune system, and see if they're noticing the bug. And then the newest piece, which it says, is the culture, which is really exciting. Because if the culture is positive, you definitely had bug there. One of the great arguments has always been that antibody testing can show past infection. And at least with the culture, if it's positive, that's real. The argument with the T cell testing, they're supposed to go away within 3 to 6 months if they don't keep seeing this irritant, the bug. So these are, unfortunately, as Dr. Kunkle was explaining, each one of these tests can go awry. So we're still not in the perfect world. But if you put them together, we're getting a lot better. And so you were talking about some other really important things, though, is that even when the bug, quote unquote, may be gone, the body is still reacting. And so you have to, you're thinking a lot about in terms of, mast cell issues or autonomic nervous system, and you said mitochondria. How do you look at that mess?
Yeah, sure. It's a good question, because I'm really excited about a new testing platform we've started working with, and I'm not sure if it'll be the answer to everything, because very few things are. But once again, if you combine the testing together, it might be insightful. And that's the IGL labs from Germany that looks at the mitochondria a little bit closer. And it also has some cool toxin assessments, I think, that are also important to recognize and evaluate. So I think if we if we follow models or theories like cell danger response, we see the mitochondria gets wrapped up in that. Your primary energy production system in your body starts to change in one way or another. And it's possible for that system to not entirely recover for several reasons. There could be less of them now, which can also happen with advancing age. They could change the way, they could fuse together. They could turn into different looking mitochondria. They could morphologically or physically change. There's no way for me to really step inside of your individual cell and just look around physically. But I'm really excited about some of that stuff, because if it gives me sort of a model to look inside of your cell and see what's not operating still, I think that speaks volumes, or it could possibly, right? And that can relate to a lot of things. Your nerves, I mentioned autonomic dysregulation, which is largely present in your nervous system, your autonomic nervous system. And guess what? The two areas that have a lot of mitochondria are your muscles and your nerves. And some nerves have an absurd amount of mitochondria. So it could be a connection point for some of these patients too, to really look at that. And we've found over time that mitochondrial therapies, quote unquote, do work better after you've treated bugs, or after you've maybe detoxed people or something like that. So I think looking at that is something newer. It's not a new idea, but it's just a newer objective tool that we can maybe monitor and then see if we can change that over time. And so if we take that through a staging process, treat the infection, work on the mitochondria and the autonomic function on the other end, and there's obviously a lot of other tools there, that might be sort of a simple model of approach. Now, beyond that, the immune system still often has to recover, and if there's stuck processes there, we will have to sometimes use different tools for immune modulation. If it's mast cell, it might be mast cell stabilizers. If it's like autoimmune type reactions, we might talk about low dose naltrexone, or even the new fun world of peptide therapies, for example, all ways to sort of modulate the immune system and try to get it to recover. And I like peptides too, because they have sort of a regenerative feature to them, I think, in terms of they're signaling your system to operate in a way where maybe it's not operating as well or hasn't been for a little while. And then it's also, some of them are really trying to actually regenerate the tissue that has been damaged. So maybe the cellular system, maybe the connective tissue in some people. And that's kind of exciting. So I think regenerative medicine practices, and there's many more of them too, seem like a good idea in some of those stages as well. And yeah, beyond that, there's more things I can talk about, of course, like the traumatic response of the whole thing and how that affects the autonomic nervous system. So doing trauma work, doing what they call limbic system retraining, among other things. There's a lot to really unload there, and it's on a case by case, and really, that can take time too. So if you get through phase 1 of treatment of the infections, there may still be a bit of a journey ahead, but that's still progress. And we'll talk about how to monitor progress here too. I think that was a question I'll maybe answer here coming up.
Yeah, no, I think that would be great. Because what you just, laying out why it's so important to have an open mind. When you see anyone with who's been ill for a while. I always want to bring up again, the things we're talking about are people who've been ill for 6 months to decades, because that's when the compensations are now as important as the triggers often are. The triggers being the acute event that got you ill, or and then you have all the ways your body has been trying to protect you. But unfortunately, once you get into the habit of self-protection, it's hard to get out of it. And so just if you and part, like I say, going through the layers, and as you said, the mast cell, the emotional response, the autonomic response, these are all pieces that we always have to keep our mind open to. So what you were going to talk about, looking how you look at these, how you measure these.
Oh yes. Well, so I mentioned a little bit, I think, so far, some of the labs that I look at and measure. And then I also mentioned, physical examination and different things like this. And I also wanted to make a note that I have people I'm going to try to have people more so do more journaling and different things too in this process to really try to monitor more subjective changes in symptoms over time too. And I think that's incredibly integral in these systems, because there's going to be a lot of waxing and waning of symptoms, and there's going to be kind of an evolutionary process here. And sometimes when you feel ill every day, it's a little more difficult to recognize progress too. So I think that really one can do themselves a favor, and they can also do the practitioner a favor by journaling symptoms and trying to write things down. Because if you also have brain fog and other things, which is quite common in these conditions, it's going to be harder to really know if anything is working. And sometimes things operate at a snail's pace, but we have to remind ourselves that there is progress being made sometimes, because it can feel like a long, arduous, sometimes hopeless journey. And it's not that there's no hope here, it's just that it's long, and it's not like an acute illness like we suspect. We're supposed to get better relatively quickly, even if we have a devastating pneumonia that lands us in the hospital. Even if it's a month recovery, that's long for most people. So years is way too long in our psyche. So we have to sort of reframe that a little bit. And one of the ways that I try to emphasize that is through the journaling of symptoms too. So I try to do my part any way I can with labs, and then I try to encourage the patient to do their part in different ways too. So yeah, that's just another example I wanted to put a little plug in for.
Yeah. Having hope is so important, and as you said, when the symptoms are there every day, and those days have gone into years, it is very difficult. I'm always amazed at the level of resiliency and hope I see in people who have been ill for a long time, because I'm really, it's impressive, because there are times when I've had acute illnesses and I'm not a good patient, and I am just amazed, because and it's what's needed. It's a difficult journey, but the hope, it has to be there. And the thing is that I can only tell people is that just because you tried something in the past, we keep learning. I mean, I'm amazed when I look back over the last, 20, 30 years, how I started with, I feel like I had Fred Flintstone tools in the beginning. All we had was, we cleaned up people's guts and we maybe killed the bug and maybe give them a few hormones, to balance things out. And we have so many more tools now, and we understand so many more stumbling blocks. And as you laid out so beautifully, I mean, like all these systems, each one of them can malfunction and can stay malfunctioning, because once the body forms a habit, it likes to keep it there, even if it's no longer serving you. So it's just so important to keep the hope, because we will come up with something eventually.
Yeah, it's a process for sure. I mean, yeah, don't lose hope. It's just it takes time, and every year we're learning something new, and there are emerging therapies, of course, too, for some of these things that are coming out. And I think those of us that try our best to kind of keep up with new knowledge and sort of cutting edge, there's a whole group of us out there, so you can find people. You may not find them the first time you look, but you can find people, so they are out there.
Yeah, and more, and I always put in a plug in for patients, because patients are amazing researchers. Even people with brain fog, I'm amazed what they bring to me. How many, because there are, in the last, it really is, I guess it is the internet. I mean, like, because it used to be ideas would just like sit out there, and now they're exposed to so many, on so many different platforms that, and again, not everything works, and some ideas are, but I think the ones that are safe are worth trying. I mean, the ones that have that are dangerous, I think we have to agree with the general medical community. We should move slowly on if there's significant downsides too. But there are so many things that we use that the downsides are minimal to non-existent. But so going on, just to go back to some of the bugs. I mean, one of the new variants has been this world of initially it was the tick-borne relapsing fever. That was a few years ago, and now we're finding a few other subsets that of Borrelia that may be the cause of some persistent symptoms. So what are you seeing in that field?
Yeah, I think one of the Borrelia species that sort of ended up, I think it's kind of moving as its own sort of entity, as an offshoot of relapsing fever, because what we learned too is that not everybody with relapsing fever Borrelia has relapsing fevers, for one thing. Some of them just have sort of nondescript symptoms of chronic fatigue and autonomic dysregulation, or whatever. Maybe they have wandering pains or fibromyalgia-like symptoms or something. So really the relapsing fever designation wasn't really super great, but it's still there, because that's kind of how we know these things. But one entity that sort of emerged and gained more understanding lately is Borrelia miyamotoi. It was originally named in Japan, I think, in like 1995 or so, and it sort of reemerged. So it was kind of sort of found in research in certain ticks. They didn't really know the significance of it at the time. And then in Russia, of all places, in 2011, kind of emerged again. They did a big case study on like 60 people or something like that, and it just showed that, okay, this is causing more illness in people than what we had recognized. So it's kind of like the idea of the Babesia coli in some ways. It's sort of an infection that's probably been around for some time, but we're starting to recognize that it may be a little bit more important to pay attention to than before. And our testing is getting better to find it also. I've had some personal experiences with Borrelia miyamotoi. I think that it is a persister organism. You can't assume it's always gone if somebody's been through extensive antibiotic treatment. They haven't even perfectly figured out what it's most responsive to. They just say doxycycline, ceftriaxone, azithromycin. And there have been some anecdotes that it works, that azithro works better for miyamotoi than other Borrelias, weirdly enough. So it's like some antibiotic that we don't always think is the best for Borrelia might be the better one. So there's a lot we still don't know from even an antibiotic perspective on miyamotoi. But what I do know is that my patients with chronic fatigue, and even those that have been through treatment, you might want to look for it. I first started finding it with this investigational test that was from Red Labs. It was a phage or phage testing. And if you don't know, phages or phages are viruses that infect bacteria. So they have a very unique signature. And so they did all this research. And so they were able to supposedly differentiate based on the presence of your individual phages, which we all have these things inside of our body, if they had this species or that species of Borrelia. So it was kind of an interesting concept. So I did that, and some of my patients with really immense chronic fatigue that have been through extensive treatment, I found a handful of Borrelia miyamotoi. So it was kind of interesting. And now I'm kind of excited about this new culture because I think it's going to pick it up better too as a direct test. Because what I realized is I wasn't always getting it in the immunoblot, or there wasn't even really conventional testing for it, I don't think. I mean, maybe Quest has one now, I can't remember. There might be one, and they're not really all that good. And it also is another one of those agents that just like screws up the B cell system or the antibody system, and that it doesn't always work. So the serology has been like not useful for the most part. So that's kind of another one that's really on my radar in the Borrelia world, and I think it can sort of exist on its as its own sort of entity.
Right. Yeah. The serology means antibody testing.
Yes. Antibodies.
I mean, that's the hardest part of being, not the hardest part. One of the difficult parts of being ill with chronic illness is learning the language. I mean, it's like nobody expected to be in the middle of this mess, and that's why these bugs are so hard to find, because obviously they are probably in lots of us, and the immune system is just dealing with them. This goes back to like the whole thing of chlamydia pneumonia and mycoplasma pneumonia, and which are kind of ubiquitous. I mean, in the population. I mean, like everybody's got them. It's just that in some people, they seem to change a little bit. Yeah, and that's the thing that's not clear, how much the bug changes versus how much the immune system has been changed, maybe by another infection or toxin, where it causes problems. It disrupts your functioning, and that's. The hope is for the future. People keep talking about personalized medicine, and they're mostly talking at this point about, genetics. But really, when we start, I don't know if I'll live long enough to see personalized microbiomes, when we really respect how different we all are, and we can get a better idea of what's living with you happily and what's living with you not so happily, because we're full of bugs. I mean, that's what I wish people understand is. So I'll leave that to you. Go.
Yeah, I didn't want to downplay the importance of the microbiome discussion. I think there's a lot of research that's really going into microbiome right now and how it relates to this whole process. And I think maybe some of the unique features of how microbiome changes in Lyme will emerge soon. That's actively being researched right now. And also on the other end, well, first of all, I guess where it all starts is our biome, our terrain predisposing us to certain conditions like Lyme? Possible. How's the environment affecting our microbiome? well, it is in a lot of ways. Glyphosate's one of them, but there's a whole bunch of other stuff too, on how toxins and everything else in our environment, our standard American diet's affecting our biome at large. And then you have, are you going to do an antibiotic treatment on somebody, especially an oral antibiotic treatment being kind of the most devastating to that biome? And is that, what's that going to leave them with too? Is that going to leave them with another layer of dysregulation or not? So this is an emerging, evolving field. It's not like we didn't know about it before, but to be able to measure that, to understand that, is what's emerging and where we're not at yet. So I think that's even the theme of, the ILADS conference this year is microbiome. So it's on all our minds, I have to say, and it's a very important conversation, but there's still a lot that we don't know. But I almost guarantee it feeds into the discussion of individual response, individual susceptibility. And it's another system I didn't want to neglect to say should be looked at in a post-treatment syndrome and should be looked to try to recover. It's the classic story, and this is in Chinese medicine, all ancient medicine systems where disease is seen as starting in the gut. So maybe everything begins and ends there. The gut is the alpha and the omega of this discussion.
Yeah. Yes. And it's what I always like to remember is I was an auto mechanic for a brief period, and I always say fixing cars is really harder on some levels than people, because you have to be perfect. When you're adjusting, the tension in an engine anyway, it's got to be pretty close to the specs. The thing about people is that they're self-healing mechanisms. So we're lucky enough that we don't have to be perfect. We just have to get close and not muck it up. And especially that's true with the microbiome, because it's so complex and it's so redundant. The thing I want people to know is that, antibiotics are not good for us, obviously, but and there are some people who small doses of antibiotics can devastate the microbiome. And then there are other people, and I have seen many of them, especially when I was in my conventional medical practice, who had been on antibiotics for decades. And surprisingly, their guts function fairly well. Again, it's the redundancy of the system. We are, some of us can be sensitive to a molecule of something, like somebody with a severe peanut allergy or some of our mast cell patients. And other people, like I said, you can hit them over the head with a 2x4 and they just, will maybe stumble backwards for a minute and still stand. And other of us, you kind of like nudge with a finger and they can fall down. And we have, this is all that biochemical individuality again, and what makes, the work that you do so important for people is because you're trying to keep an eye on all these levels all the time. And that's where that history that you have learned to take, from the different systems that you've studied, you're always looking at the balance points, and that's what's really, really exciting. And what we have to keep in mind is that we don't have straightforward answers, but but if you keep asking the right questions, we can hopefully modify our treatment so we don't hurt people. And so anything you want to end with, any words of wisdom on approaches to chronic illness that guide you?
Yeah, sure. I mean, I don't know what I could say that I haven't already said, but I just leave you with, the hope discussion is important, of course. Don't lose hope that there are people out there that are really working with this intently to understand it, and your individual case is different than others too, so you don't need to compare yourself to other people. You're an individual, and you need somebody that's going to work with you as an individual too, and try to understand the you of this particular situation. So those people are out there, so don't lose hope. And you can, as we gain more knowledge though, we're going to have a better foundation to really support these things, I think, in the very beginning. And maybe it starts with, prevention is always the best medicine, of course. So we catch things earlier, we can treat them earlier, everything can be better. And then for, just generally speaking, for myself and other practitioners, just keep learning, keep an open mind. Don't get stuck in in old ways, models or paradigms of understanding, continue to evolve that, and be sometimes, you know, be nice to yourself, of course, but also be willing to be self-critical sometimes too, because your patients really are the best teachers. They're the best teachers for me. So things that may be perceived as mistakes or learning experiences, or if you don't improve them with something you thought was going to be super cool, that's a learning experience too. So just continue to evolve, to move forward, to try to understand, and really don't compartmentalize the human body. It's all interconnected, every little bit of it. And I didn't want to neglect the hormones and the endocrine system. I just didn't talk about everything, but I consider everything.
Yeah. Yeah. No, I mean, that's what's needed, is because we don't know what is the linchpin in your system, you know, and that's what always makes me upset when people, you know, think that if they fix their gut, everything's going to, and we've all seen the miracles. Fixed one thing and everything falls into place, and God bless, that's a wonderful event. But unfortunately, for most of us, it's a lot of small steps that get us back to health. But that is the goal. And Dr. Kunkle, it's really an honor and a pleasure and a privilege to have you working with us and part of our team, because it's I said, there are not many doctors out there who really can hold as many viewpoints that you can. So I really appreciate having you. So, thank you.
It's been a pleasure.